The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell, and welcome to our weekly Safe and Calm webinar. We certainly appreciate your flexibility as we've had a lot of meeting conflicts this week. We want to take a moment again to recognize the challenges that you all face every day in serving our seniors. We know that it is hard on those front lines. But we also recognize that there's a lot of challenges and confusion around the number of guidelines and directives, and that you're also dealing with revenue issues, cost issues, and sometimes insufficient resources. So as we kind of move forward in this challenging time, I want to start off with some really good news, at least for skilled nursing facilities. Blake, can you move it forward? So we heard from Plant Moran this morning, who gave us a heads up that there's a dedicated CARES Act distribution of $5 billion just for nursing facilities. Letters are going to be sent out to all current providers based on your tax ID. So each facility in the nation will receive a basic grant of $50,000. And the remaining approximately $4.2 billion will be distributed based on the number of beds. And Plant Moran estimated that that would be about $2,500 per bed. They've also postponed the attestation window. So remember that these are grants, but they're grants with, they come with guidelines. And you have to use these monies to offset your lost revenue and your additional expenses because of the COVID pandemic. Plant Moran also says that you should remember that you cannot attest your willingness to receive the funds and use the funds for those appropriate purposes without your United Healthcare Group deposit number. And without some third number, you'll be locked out. They were going to be sending out a more detailed guidance about that when the details are coming. But we think that the HHS is going to announce this today. So that's really good news for at least the nursing facilities who may be struggling with revenue. So we're going to follow our routine agenda for the morning. We're going to start with advocacy, and we will follow with our situation summary and then an overview of recent guidance and directives. Just a few housekeeping things before we move on. You'll note that under handouts, there are two separate PowerPoint documents. They're the same, except one is a PDF and one is in PowerPoint. So just to make sure that you have some ease in trying to access those things. Also, if you have questions, remember to enter them into chat format, and any documents or directives that we identify here, we will send the link in our Q&A, which will follow. So we'll turn the presentation over to Dalton for an overview of the Lansing environment and leading edge Michigan advocacy.
Good morning, everyone. To start off, and in honor of Memorial Day, we wanted to pass on a sincere thank you to those who have served in the military or those who have family members who serve in the military. Thank you. As Deanna said, today we'll be providing some updates on Michigan's political environment and Lansing's political environment, as it has changed a lot from where it was pre-COVID. Underneath this update, we'll be talking about Michigan's budget, the Republican lawsuit against the governor, the Senate Oversight Committee, a brief update on the regional hubs, and an update on the legal immunity bill, as well as some updates on visitation and testing. To start off, Lansing's political environment has truly changed in the last couple of months. 2020, as many people know, is a big election year for Michigan and the nation. Michigan's political environment has became very strained, as Michigan's politicians would normally already be in campaign mode. The election is what, 5 months-ish away, a little less. And normally they'd already be out campaigning, but with all the things that are taking up their time and all the things that they need to do, the campaign season has just been thrown off. Because of this, they are expecting to take a break in July/August to start the campaign season and then come back throughout that time period until the actual election to get work done as needed. To accomplish this, though, they want to get the budget done by July 1st. That is a stretch, though, because even the data won't be complete by then. And members and Michiganders can anticipate another very active lame duck session this year. As I said before, to paint a further, more detailed picture, we'll be looking at the budget, legal suit, the Senate Oversight Committee, regional hubs, and legal immunity. Michigan's budget, as if you were on the call last Friday, you will know that we are facing a massive budget deficit. They anticipate the budget deficit will be $6.2 billion for this current and next fiscal year. For this current year, $2 billion, there's $2 billion less in the general fund and $1.2 billion less in the school aid fund. This is especially troubling for schools as they're already into their fiscal year. So they've been spending money that they haven't received yet. Legislators are hoping for a federal relief package to fill the hole of these 4 schools. As far as the general fund, there's currently debate amongst political people in Lansing. Senate Bill 690 recently passed the Senate and is a budget supplemental bill. And this allocates some of the Federal CARES Act funds to some of the Senate's policy priorities. This includes the $3 an hour increase for direct care workers and SNFs. However, this bill is unlikely to go anywhere as the CARE Act funds are at the sole discretion of the governor. And by passing this bill, the Senate was attempting to redirect funds that are underneath the governor's authority. And it is largely a move designed to bring and highlight the Senate's policy points for future budget negotiations. And on Thursday, we saw the first kind of action that normally takes place when they're looking to start budget negotiations. The Senate and the House both passed blank budget bills, which allows them to quickly move on any kind of solution they have because they can fill in the blank text later once they get the negotiations complete. To briefly touch on the lawsuit, as you may have heard, yesterday had some big news regarding this. The legislative Republicans were suing the governor for overreach and overuse of her executive authority when she extended the state of emergency. A couple things that went into this: the legislature did not extend the emergency themselves, and that came after the governor's office leaking negotiation emails to media outlets. And so they're not exactly on the same page right now, but we are hopeful they'll figure some stuff out going forward. Last Friday, the case wrapped, arguments finished, and yesterday the court ruled in favor of the governor that she has authority to extend the emergency under the Governor's Act, but not underneath the Emergency Managers Act. There's also been a bunch of other injunctions filed against the governor, but many of them have been denied. The Republicans are looking to appeal the case, but no action has been taken at this time. The Senate Committee on Oversight is a committee that was formed to investigate Executive Order 2020-50 and the transfer of COVID-positive nursing home residents into long-term care facilities. Most Republicans and Democrats have come out against the governor's executive order, and many feel that it might need a legislative fix. Many are signaling that they might try to get some kind of legislation passed in the near future to kind of add clarity to this executive order. We have been working with the department and the legislature and with this committee in particular. We've been very active with it, and they invited us to testify on Wednesday morning, which we did. Our testimony was designed to describe the impact of the executive order on both our members and on the lives of the people we serve. The legal immunity bill, some I just got an email this morning with some updates about this. The idea for legal immunity for healthcare providers has become a partisan issue. As some of you may know, Mitch McConnell has using it on a national level as a policy point for his negotiations for future COVID relief packages. Also, other states who have passed legal immunity legislation have had bills introduced in them to remove these protections from the providers. So it's getting a little contentious. In Michigan, the Senate bill provides legal immunity to healthcare providers during the pandemic and has been stalled in the House Judiciary Committee. The last couple of weeks, there has been testimony on it from numerous healthcare provider groups, including us, including hospitals, pretty much everyone. But there is a large concern that the bill does not hold healthcare groups accountable for providing PPE to their employees, and it has been taken off the agenda for next week. We will continue to work with policymakers to nail down the language and to ease the concerns of policymakers as we feel this is a necessary step for the future of healthcare in Michigan. A brief update on the Regional Hubs program. This map on this page is a quick Google map that I whipped up that shows the location of every regional hub across the state. There is also one alternate care site in Novi that is not on here, but that would just be another point in the large cluster in Southeast Michigan. Some program information for regional hubs. The Department of DHHS is still looking for additional skilled nursing facilities who wish to become a regional hub. They're especially looking for hubs in the Midland, Bay City area and in West Michigan, Grand Rapids. As you can see, they only have one hub for all of Grand Rapids. The general terms of the hub program are that providers will be afforded about $5,100 per COVID bed to offset the development costs. And MDHHS is still working on the enhancement to the Medicaid rate. You must meet their conditions of participation, and the program is no longer a voluntary in, voluntary out. You have to agree to be a regional hub for a set period of time. Currently, there are 20 regional hubs in Michigan, and they are serving 9.5% of all COVID positive residents. I've included the email down here for those who might be interested or have questions about the regional hub. That is the state's email for regional hubs. This is just a list of the regional hubs in case you are interested in the exact names, locations, what companies are doing it, and some contact information and where they're located. I just wanted to provide the information to you in case you didn't have it already. Testing. As we know, testing and visitation guidelines are going to be key going forward here in Michigan, and I believe Deanna will touch on testing a little bit more in detail later. In Michigan, the National Guard has been assisting long-term care facilities with the voluntary testing of staff and residents. This includes all skill levels of care. The test kits should come with instructions for use. We heard yesterday on a call that I believe some of you may have been on that some of the test kits were missing instructions. So if you did not receive instructions, please let us know so we can get those to you. Testing and support services have been focused in the counties that have been hardest hit by COVID. They also put some resources towards Region 6 and 8 of the governor's reopening plan so that they could be sure that those sections can reopen safely. At the moment, any tests provided through the National Guard will be paid by the state of Michigan, and paid for by the state of Michigan, I should say. The state received $315 million from the CARES Act to provide these tests. Leading Age Michigan is well aware of the CDC and CMS guidance that suggests weekly testing and our members' concerns of who will be paying for these tests and in the future and currently. So we'll be reaching out to these providers and already have, and we've started conversations to figure this out. On a side note, we received news that on Wednesday or Tuesday of this week that Larry Horvath, the director over at LARA, received word from the governor's office that she wants to start a visitation and reopening committee for long-term care facilities. But then the Midland flood happened, so then things got delayed by a couple days, but we just received word this morning that they are going to be sending out invitations and to those who have been selected for this committee today. So I know we do have a couple members on this committee who have been invited to participate. So thank you for your work. There's going to be a tight timeline for this committee because the governor wants to get this done by the end of May. So that gives you about 8 days. So thank you to those who served, and we'll be having some more discussion, and further information will be coming on visitation guidelines. I believe this is the questions page.
Yes. So before I do ask any questions, Leading Age Michigan would like to extend our sincere appreciation to our generous business partners who continue their support of our annual conference. Despite it being temporarily postponed, we look forward to your continued collaboration, and we remain grateful for you. As you can see on the page, this is everyone who has stuck with us as a sponsor throughout everything for the Leading Age Michigan Annual Conference. Now, I do have a couple questions. The first one is, how do you find the UHG deposit number?
This is Deanna. I believe that it would be on the documentation of the monies that would be coming into your deposit account, but I would have to check with Plant Moran to be sure. So we can search that out and put it in the Q&A.
Oh, okay. And then I have another one that says, we were informed by Washtenaw County Health Department that these tests are limited only to sniffs and were not provided testing for our ALF and AL.
My understanding is that they are focusing on nursing facilities at this time. There is a testing work group specific to AFCs and HFAs. I don't think that they are as far down the path for their planning. I think that that piece will be coming next. I don't think that they're far behind the SNF testing plan, but I'm not sure of any exact dates when they will move forward. But they're definitely focusing on nursing facilities first.
Okay. And then I have one more question, it looks like. So are facilities proceeding to test all residents and staff? How often are we essentially waiting for more directives, or should we be proceeding?
That's a really good question. And I will speak to it a little bit more in detail a little bit later. Basically, the state does not have a plan to retest now. They do plan to get that plan, but they don't know the frequency. They don't know how they're going to manage it. They don't know how they're going to pay for it. So there is no plan at this point. I would think that if you have resources, you might consider moving forward with your own plan to do that. That would be, an individual facility decision as you look at your individual circumstances.
Okay, and it looks like that is the last question, so we can go ahead and move forward now.
Okay, well, we will just take a quick look at the situation summary in Michigan. As we watch the pandemic move forward, I know that there are, I know that the numbers don't sometimes seem to be moving very fast, and some of the information is very similar from week to week. Go ahead and move the slide forward, Blake. But there's a couple things that I just want to make sure that we're all aware of. This is a recent graph, I think it's from the New York Times, about new reported cases worldwide by day. So these are daily new cases, and you notice that it's not going down. And there's definitely areas where it is going down. Unfortunately, though, overall, the cases are still spreading. So we're still in, a fairly we're not at the end of this pandemic yet. And of course, we're always worried about, a second surge as well. This slide, it tends to look the same every week that I put it up here. It is the 7-day rolling average of deaths. And the United States is still accounting for about a third, a little less than a third of them overall. But in reality, it is becoming less, the graph is becoming less deep, if you would, on the far right side if you're looking closely at it. So although the proportions of deaths per country kind of look the same, they are going down. That is one very positive thing. The number of deaths are going down, both in the United States, Michigan, and across the world. I thought this was kind of an interesting slide. This, again, I think came from the New York Times as well. And it was a description, I think it was as of May 17 or 18. I think I pulled it down on the 20th, where which states were actually declining, which states were in a flattening mode, and which states where it was still increasing. And I think one of the important things here is that you do have to look at the states that surround you. A lot of the CDC experts are warning that if you can reopen Michigan or not reopen Michigan, but if you reopen Michigan and Ohio's not open yet, that's going to impact Ohio. And if you reopen Michigan, some spread could come from those surrounding states. So they're calling for a coordinated effort in looking at how the state should reopen, and we'll just have to see how that plays out. This is the 7-day rolling average in Michigan for daily new COVID cases. And you'll see the last couple of days it has taken a dip downward again, but the new cases really have kind of taken another hike. Overall, if you look week to week, there is still kind of a decrease, but when you look at the daily rates, it's going up just a bit. And I think that's important as we reopen. This slide, these slides came from Time, identifies the 7-day rolling average of cases per 100,000 people. So you'll notice the graph looks really similar. The green identifies the period of time where we were actually declining, and somewhere around May 17th was really the first time when we were significantly declining again after a while. This is the 7-day rolling average daily new deaths in Michigan. Notice that it has pretty much consistently decreased. It has flattened out for the last week or so. We can anticipate, though, that the death numbers are going to go up, not because necessarily that we have a real increase in deaths that are related to COVID, but more because Michigan is changing the way that they're going to identify COVID deaths. Apparently, right now, they only provide data as they only list a death as a COVID-related death if there was a positive COVID-19 lab result. So there's a lot of presumptive cases, and in the early period there was inadequate testing, so that they're going to start including deaths that have a presumptive COVID diagnosis without a positive test. The reason they think that this is really important is that when you take the COVID known deaths out of the mix, the deaths for the calendar year 2020 so far are 21% higher than last year. So they believe that they're missing a lot of these deaths and that the death rate may well be a bit higher. Another dilemma is that every state has a different way to define and measure how to identify a COVID-related death. So when you're looking at Michigan versus other states, everyone isn't necessarily measuring it the same. So we want to again thank you to some of our exhibitors who have hung with us through this pandemic. And are there any questions about the situation summary?
All right, so I have a question. What are the reporting requirements today, and what are the time frames for reporting?
I'm assuming you're asking about the reporting requirements for individual facilities or deaths. I guess I need
She
a
said
little bit more
HFA.
information. I'm sorry?
She said HFA.
HFAs and AFCs are not currently required to report. They are, and we'll talk about this when we get into the new executive order. They are required in the executive order, just like skilled nursing facilities are. However, the state has not completed its system for HFA, AFC, and somehow or other unlicensed assisted living. I haven't figured out how they're going to do that yet. Reporting, I do know that the elements will be the same that skilled nursing facilities have to report, but it is not completed at this time. I do think that they will apply the same rules and that you will have to do daily reporting when it's done.
Okay. What about reporting to residents and families of positive cases?
There are rules in the executive order, and in fact have been in the executive order 2050 for positive cases all along to families. I would have to pull that up to look at it, but I believe that you have 24 hours, but I'm not sure. I would have to look at that again. I do know that you have to report to your own staff within 12. And I think that you have to, I think they changed some of the wording of this, but I think you have to report to families within the next day. But I will check that and make sure that it's in the Q&A.
All right. Those testing guidelines are recommendations right now and not mandatory. Do you see repercussions if we decide not to do it unless mandated? We are a small facility and COVID-free so far, both staff and residents.
Well, let's talk about that a little bit more when we get to the testing piece. I think that there's a lot of issues about that. Some of the facility fears that their staff may end up being COVID positive have come to fruition in a few of the, at least the western side of the state. I know of 2 facilities that found they had quite a few staff that were positive. However, I have to say that, you know, not knowing is not necessarily better. So, but we can talk about that a little bit more. And if you have another question, please ask me when we talk about testing. Testing is a big subject coming up.
All right. That was the last question, so we will go ahead and keep it moving.
Okay. So we're going to look at guidance and directives now, we really are trying hard to make sure that we keep up with every guidance and directive that comes out, which are quite a bit. And it seems like the CDC and the executive orders are pretty much the big things that have come out in the last week or so. So CMS has put out a directive, QSO 2030 -NH, that speaks to the criteria for relaxing restrictions in nursing homes. They speak to the need to continue to mitigate risk as best as you can. Visitation and service considerations, that's a huge issue as we've talked about earlier. And again, there is a LAURA work group being established for that. And also the restoration of survey activities. So CMS envisions that state officials will work with the survey agency, the local health departments, and other entities to decide how and when to apply these criteria and any other actions specific for Michigan. They are talking about 3 different ways that the state could look at this. They could put a phased approach across the entire state. And there is no approach that CMS has recommended that isn't phased. So you can't just open everything up all at once. You really have to open things up a little bit at a time and then see how it goes. So you can do it across the entire state, or you can do it in certain regions that don't have a lot of COVID infections, or you can do it based on the status of an individual nursing home. So I assume that these are some things that the LAR work group will be looking at. So they suggest that all of the decisions about whether to open statewide, regionally, or in a facility have to be based on a number of considerations and should be done in collaboration with state and local officials, and they did include nursing homes. I do think that it is really important for us to have a voice in those decisions about impact and the problems that we have encumbered really with visitation and the pandemic overall. They suggest that you really need to look at the amount of community transmission. If you're in an area that doesn't have a lot of community transmission, you're in a much better position to open up. Cases in the nursing home itself, they pretty much are expecting that you will not be able to open up visitation unless there are no new nursing home cases for a significant amount of time. You have to have enough staffing, you have to have enough testing materials, you have to have enough PPE, you're going to have to maintain universal source control for a long time, and you also have to look in your area to make sure that your hospital has the capacity in case there's a resurgence. Testing. So in order to continue down this path, CMS recommends that every facility has to have a testing plan, and this speaks to the piece that is reflected in the question earlier. Each facility is going to be required to have a testing plan in place based on the contingencies informed by CDC at a minimum. So if you all don't have a testing plan, you should consider that. And I think that that's really hard right now because of all of the unstable issues in Michigan about testing. But CMS is strongly recommending, although the state has some final word here about the capacity for all residents to receive a single baseline test. That should be completed by the department. But then again, the capacity to test all, if you identify another resident with symptoms or anyone else with a positive test, and the capacity for continuance of weekly testing. What I think will be very interesting here is CMS put out these recommendations. But, you know, CMS usually doesn't recommend things to nursing homes. They mandate things to nursing homes. So it's unclear within this framework how much they're going to hold us to, even though the state has the final say over a lot of this. And that's something that I think that we need to bring up with CMS moving forward, how that's going to all play out. Because it's not unusual for us to find, you know, the state may say one thing, but the surveyors may come in and say something else. So that's kind of a gray area here that I hope we find out more about soon. Have to have the capacity to test, have to have the capacity to test all nursing home staff, volunteers. You have to have written screening protocols. You probably have that now. Those screening protocols don't change much during any of these phases. Another piece is that you have to have an arrangement with labs to conduct the tests. And they're not looking for antibody tests at all here. They're looking for the actual COVID test itself for the virus. And I guess that's a big issue. If we don't have labs available to do that, I don't know how these arrangements are working in our local communities with our members now. I did think I heard a question, someone didn't think that they had a lab resource to do all of these tests, and that's a possibility, and I think something the state's going to have to look at as we move forward. And lastly, but not least important for sure, is that these tests are not mandatory. They are volunteer. But what are you going to do if a resident refuses a test, or a staff person refuses a test, and you have COVID around you? That's going to be problematic. And CMS has identified that you need to have a procedure for addressing that and consider the idea that symptomatic cases should be treated as positive, which would be very, very difficult if you think about it. So I think that that's a little bit of a dilemma too that we're going to have to look at as we move forward. Phase reopening. So the CMS guidance phases the reopening, and it kind of is in alignment with the administration's Opening Up America Again protocol. It depends on rigorous infection prevention and control. So I can't imagine that there's a member facility out there that hasn't looked at all of its infection control policies and practices, but that is something that has got to be a very, very focused effort moving forward. Nursing facilities should not relax any restrictions until all residents have received a baseline test and you have responded appropriately to those findings. They suggest that states should survey nursing homes who've had an outbreak prior to their reopening. In other words, if you've had a recent outbreak, they want to make sure that you get an infection control survey so that you can prevent further transmission. And nursing homes must stay in the state of highest mitigation while the community is in phase one. In other words, if the community matches the government's phases for loosening restrictions, the nursing home must stay for at least 14 days in their highest state of mitigation, which is where we are now, and has to do that for at least 14 days before they open up. They want to see what's happening in the community before they open up the nursing homes to make sure that there isn't a surge. So the current state, our current state, I would call phase one, high vigilance. And these are all the criteria that we pretty much are working under now. Visitations prohibited except for compassionate care, universal source control across the entire facility, restricted entry of non-essential personnel. Communal dining is limited. There are some social distancing parameters that you can use, but there's nothing on here that you haven't done to date, except all staff have to be tested weekly. So before you can even move to the next phase, according to CMS, facilities should be testing weekly. And again, that is something that we will have to look forward. And this, it does specify staff, doesn't necessarily specify residents. So I really think that the LARA work group is going to have to work with the testing work group and see how all of that plays out together. And last but not least, you need a dedicated space for cohorting in case something happens. The newest emergency order changed its language from those with 80% occupancy or lower needing to create a dedicated space to a strong encouragement that everyone develop a dedicated space. So those are the two pieces that might not quite be so easy. Go ahead, Blake. In phase two, there are some community requirements. There has to have been no rebounding cases after 14 days of opening up that community during phase one. No new nursing home cases for 14 days, no staffing shortages, adequate supplies, and referral hospitals with capacity, including intensive care. There's some limited opening of visitation here. Pretty much, though, it's mostly the same. For phase two, they see limited entry of non-essential personnel with precautionary measures, which means universal source control and screening. And I think that is the only other thing that's changed is non-medical trips and group activities can start for asymptomatic and negative persons for no more than 10 persons at a time, and you have to maintain social distancing. Other than that, all of the requirements that we have in place now are still in place in phase two. Phase three, no new nursing home cases for 28 days. Again, you have to have staff, you have to have supplies. There is a little bit more loosening up. Visits are allowed. You have to continue to screen. You have to continue to social distance, and everyone still has to wear a face mask. You still must have universal source control throughout the entire facility. Communal dining hasn't changed. I think everything else is still the same. And remember that staff is still tested weekly, and especially upon identification of any cases, until all the residents are negative. Survey activities. Survey activities will increase starting in phase 2. They will focus on complaints and facility reported incidents with any allegations of abuse, neglect, infection control complaints, violations of transfer and discharge requirements, any staffing or staffing competency issues, and some other high level quality of care issues. They anticipate restarting standard recertification surveys based on the following criteria. If you have a significant number of COVID patients, you're going to be at the top of the list. Special focus facilities and candidates are next. And then anyone overdue for standard survey and who might have a history of G-citation for any of those areas that we discussed earlier. So in phase 2, you can expect a beginning to return to normal survey activities. Reopening senior living. Leading Age has put 2, I think, amazing tools out. Recovery considerations for affordable housing and recovery considerations for life plan communities. There's an amazing decision matrix for affordable housing providers. I think these are great documents that are very, very helpful. We will provide links to them in the Q&A. And also, we will also provide a link to the May 21 HUD update for multifamily housing. But again, I strongly urge our senior living providers to look at these documents. They're very well done. Okay, on to the CDC. The CDC has put out some new materials in the last week. They did almost a huge paper on activities and initiatives supporting COVID response. I think you might get something from reading that, although I wouldn't require it. It just talks about some of the work that they're doing with a huge focus on expanding and prioritizing patients for testing. Testing is definitely the topic of probably the month. These are some other things that they're working on in terms of assisting both local areas and the nation altogether. They have updated their guidance of training for healthcare professionals. I did look at it. I didn't think it updated much. A little bit of an update also to the clinician guidance for treating persons. That's very, very clinical and meant for physicians. And this is just a reminder that our IPRAT teams in Michigan are going to be using the ICAR tool, which is a CDC tool on infection control and assessment. So you might want to look at that, and again, that link will be in our Q&A. Preparing for COVID-19 in nursing homes. CDC updated that webpage as of May 19. They talk about tiered recommendations to address nursing homes in different phases. Recommendation to assign an individual to manage infection control programs in facilities. That's a strong recommendation. We all know that, and I'm fully aware that there are very few full-time infection control nurses, but the reality is that it is so critical now that they are strongly suggesting that you have an individual dedicated to that task and to monitor that program. They also put out a guidance for reporting to NHSN for skilled nursing facilities and recommendations for plans to test residents and healthcare personnel. Those are all new pieces. There will be links in the Q&A. So looking at the detail, this is the May 19 guidance from the CDC on the left. They identify that health departments must have a strategy for prioritizing testing based on the number of cases, community prevalence, or exposures. They are supposed to have a plan for serial testing after baseline. That's what we've been talking about a lot this morning. And to identify residents early who might should be prioritized. Their plan should include the type of testing to be done and the kits required. They think that they should also be looking at infection control practices in facilities and consider how these tests will be ordered, who's going to order them, and how they be funded, and should be putting out some local guidance. So on the right, I've listed what Michigan's actually doing compared to those recommendations. The MDHH testing work group identifies the priorities for baseline 100% testing using EM resource. So what they did was, if you remember, there was a survey, and I believe that AFCs and HFAs have also received a survey after that in that plan to get them tested. And they came up with priorities by county, and we'll talk about those counties in a moment. There are no concrete plans from the department for how to follow up that baseline testing, as we talked about before. Most facilities and most kits are for nasopharyngeal testing, and the goal for right now, using the National Guard and the local health departments to support facilities who do not have kits. I do believe that in most cases, the facilities are being asked to do the tests themselves, collect the specimens themselves if they can, but I do believe that support's available if you do not have the ability to do that. Talking about evaluations of infection control, we currently have IPRAT teams. I don't know if you all received a visit from them or a contact from them yet. They are working very hard with the testing work group to identify facilities who might be in need of assistance in terms of infection control. We have LARA survey-related infection control surveys, and of course now in the last week or so, QIOs have been contracted with the HHS to provide some guidance as well to facilities. I'm not sure how they're determining who to reach out to, and I've not heard anything more about that other than the fact that they will be out there. The department is suggesting that medical directors do the ordering, and again, we have $315 million for baseline testing, which is what is supporting the current initiative, but there are no plans at all to figure out how to pay for the ongoing testing follow-up. And although they expect local guidance, it's obvious that in Michigan, the state is managing this. Granted, through working with a number of individual entities, it is definitely the state work group that is making those kinds of decisions. So the current testing plan, the Upper Peninsula was finished, all congregate settings there, not just nursing homes and AFCs. I do believe that they did do all of the long-term care settings up there, though, but also prisons, other places where there's congregate living. All of that was completed about 2 weeks ago. Then local health departments were asked to develop a top 10 nursing facility list in their area to identify the nursing facilities they thought needed perhaps testing more than others. And then the department did a survey, if you remember, looked at the data and identified the top 10 next counties. I'm sorry you can't see that very well, but it's Oakland, Wayne, Macomb, Genesee, Saginaw, Ingham, Kent, Muskegon, Washita, and the city of Detroit. The darkened ones, Oakland, Genesee, and Kent, started last Monday, and we heard reports that the National Guard was doing testing or assisting with testing very, very rapidly in those areas. They will go to another 3 areas shortly, and the next phase will probably include Kalamazoo, Calhoun, St. Clair, those counties that are listed there. Now, that's subject to change. This is, if you notice that these counties are not necessarily near each other. It's not a regional kind of thing. It is based on the number of cases that they're seeing and the problems that they're seeing. So they're definitely prioritizing this based on COVID need. Facilities in these counties should expect a contact from your local health department in order to discuss how to coordinate this. This is the work plan from the nursing home testing work group. You'll note that there are a lot of issues here, but basically we're working on number 3 right now, which is finishing a 2-week schedule for the next 10 counties, identifying the next 10 counties. Toward the end, one of the things that I wanted to make sure that everybody could see here is starting with number 9. They were thinking about developing guidance for the qualification and the practice to actually collect the specimen to make sure that nursing homes knew how to do that well. They were going to refer to a CDC guidance, and they're thinking about putting something out about that. We suggested that we also need some additional guidance about what the retesting plan is. And of course, they don't have a retesting plan, but we have very strongly encouraged them to figure this out, because time is flying by and we don't know how we're going to get our facilities open unless we have a retesting plan, and how will that play out. Coordinated cross groups, developing testing guidance to develop the final guidance. In other words, there's an awful lot of stakeholders in these areas. There's the Michigan State Police, there's the local health departments, there's the healthcare coordinating body in every region, there are the provider stakeholder groups. So there's a lot of people to work through this, and the department has really worked hard to try and include input from everyone. The problem is they just haven't figured out how to get follow-up testing done. What is a very real problem is the challenges to nursing homes if they find a lot of their staff test positive. We are having follow-up conversations about that all along. So far, I have to say there's not a good answer to that. The only thing that might be considered is that if you have asymptomatic positive staff, the CDC does allow, they call it last resort, however, them to take care of COVID positive patients. So, that is certainly a possibility as you're trying to identify dedicated staff for your COVID units as well. So I'm hoping that the state will consider that moving forward. We'll see how that plays out. So last week, the state sent out a provider letter L32. It spoke to the need to continue to transmit your SNF data to EM Resource on a daily basis, but also gives nursing facilities the opportunity to use the data from EM Resource and send it automatically to NHSN, which I think is a pretty darn good idea. In fact, the state changed its definitions for some of its measures to match the CDC requirements. You don't have to use that system to submit to NHSN, but you can. If you do, you have to fill out a one-time reporting piece in EM Resource that identifies your contact information so that they can be sure that they're matching the data from EM Resource correctly as it feeds into NHSN. There are also, in this updated guidance, some minor changes to some other data elements. We suggest you review that, and again, this link will be in the Q&A. Expansion of 2020-50, 2020-84, now it's called 2020-95. This is, of course, the executive order that has caused a large amount of concern and pretty much is focused on regional hubs. There are there were a few changes in this from the original writing, but a lot of it remains the same. The definitions remain the same, so that I wanted to point out that a long-term care facility in this EO means a nursing home, a home for the aged, adult foster care, or assisted living facility. So when you read it, there's also other guidance that says, well, but regional hubs are just for hospitals and they're just for nursing home transfers. They're not for adult foster care or assisted living transfers. And the reporting mechanisms currently do not apply to homes for the aged, adult foster care. But those are the only two areas that those home for the aged, adult foster care, and assisted living are not required to do. So you have to look at this executive order as you would have 20/20/50 and understand that except for those two areas, it applies to pretty much all of senior residential living. The only other thing that I might want to point out in definitions is that they've included swing beds now. They are strongly encouraging hospitals to develop swing bed capacity because they now have a waiver from CMS to do that very rapidly. Swing beds in hospitals are only supposed to use when there's no alternative in the community. There are three sections. I put the first section on this slide, the protections for resident. There are no changes here. So if you look at 20/20/50 or 84 or 95, it says the same thing, which some of those things I still don't understand very well, nor deny resident access. Just a blanket statement. You cannot effectuate evictions for non-payment, nor deny a resident access. I still don't know, to be honest with you, what that means. Can't prohibit admissions based on the testing. In other words, you don't have to wait for testing from the hospital in order to admit a patient, as long as they're not COVID. They have changed that in a later section of this. But if they're not COVID, you're not sure, they might have been exposed, you still can't prohibit a readmission back to your facility while you're awaiting testing. People who have voluntarily moved out must be able to return. I still don't understand the point of that either, but that's still in there. A facility must not accept a return of a resident if there's no dedicated unit or if you are not a regional hub. That's still in there. And I think that if I were going to identify maybe a better sense of the changes in this executive order, it would be about trying to better protect the residents in nursing homes from COVID positive patients coming in. I would say that that looks like the intention. The next section is protections for employees and residents. Again, there are no changes here. You have to inform employees of cases within 12 hours. And no changes here. I think that the other section about reporting is in transfers and discharges. Excuse me. By the way, this executive order extends to June 17th. Sorry. So you must report to the local health department any COVID case within 24 hours. You must transfer medically unstable. Neither of those things have changed. All of those facility levels must make reasonable efforts to create a dedicated unit. They got rid of the 80% rule. If you have a dedicated unit, you must provide appropriate PEE. If you don't have appropriate PEE and staffing, you could have a dedicated unit, but you still can't admit people. So you have to make sure that patient safety is foremost. You can designate an entire facility to be COVID related. You must not create or maintain a unit unless it can implement effective and reliable infection control procedures. One of the hard things I think about this is trying to figure out, what is effective and reliable, and isn't that to some degree in a judgment? But I would say that if you can't meet the survey criteria for infection control, if you don't have staffing, if you don't have PPE, you really don't have a dedicated unit. The protocol for stable positive COVID residents is they should go to a dedicated unit if you have one, a regional hub. an alternate care facility with capacity or a swing bed, or you can send to a hospital. However, we have said all along that those things pretty much do not exist. The regional hubs, the capacity is very small. Alternate care facilities have not taken any nursing home patients that I'm aware of. Swing beds, I'm not sure, are in existence beyond that which they were before, and hospitals generally have not been taking COVID positive patients who didn't require a higher level of care. So there's still some concerns about that, but that is the protocol again as written by the state. Hospitals must test post-COVID patients prior to discharge. So that's new. That is a piece. Note that if you have a non-COVID patient, you cannot wait for testing to come back simply because they've been in the hospital and potentially exposed. But if they are post-COVID, they have to be tested prior to discharge. And I think that that's a new piece that is really designed to try and protect the residents that are currently in our member facilities. Discharge destinations, you need to consider patient safety, safety of residents, family and resident wishes, and guidance from the local health department. Residents can only be discharged to a capable facility. Hospital must keep the resident until acceptable destination is found. And technically, although that's written there, that has always been a requirement for hospitals in reality. Here, you must notify residents and representatives within 24 hours of identifying a new case. Or, again, remember that it's 3 persons or staff or resident who developed symptoms within a 72-hour period. You still must do that, and that applies to all provider types. Laura is authorized to take action to ensure a proper level of services, and the rest of this is unchanged. So there is more of an emphasis on patient safety, especially for the residents that are non-COVID positive currently living in your facilities. Reinforcement of Executive Orders 69, 71, 91, 92. I just wanted to focus a moment on the fact that the department put out an emergency order that pretty much says if people are violating the stay-at-home order or their business restrictions, that violations will be referred to the appropriate licensing facility, and that law enforcement can follow up and investigate, and criminal penalties are possible. Regional hubs and dedicated units. There is a guideline for regional hubs and dedicated units, and I scanned it when it first came out probably a month or so ago. I looked at it in detail again this week. It does have some requirements for regional hubs that go above and beyond that of a normal nursing care facility, but only in very limited ways. So if you're looking for guidance to create a dedicated unit, what it needs to look like, how to really make sure that you have effectively separated it and the risk from the rest of your facility, this is really not a good place to go. I will put the link for this in the Q&A, but our goal is to take a look at the CDC and try to identify some cohorting. I know that there are good cohorting criteria in numerous of their web pages, and we're going to try and coordinate that for you. Okay, so this is pretty much the criteria from the guidance from the department. I'm not going to go through this. I think that you'll find that basically it just says you have to have a separate wing, separate entrance. You can repurpose an emergency exit. There's been some discussion about that. Have to have a isolated nurses station, linen. Anything that you need has to be in that unit and separate from the rest of the facility. And then there's pretty much when it's appropriate to send someone to a regional hub. I think that might be interesting for some members to read the appropriate admission from a nursing facility, from a hospital, or from an alternate care facility. They do have transfer forms, a surveillance form, and a discharge checklist that they require to move people into the hubs. And those look like pretty good tools. I'm not sure that they are that much different than the tools we would already be using, but they look like pretty good tools as well. So that ends our webinar for today. I'm sure there might be some questions. And again, we want to thank some of our exhibitors who have been really, really supportive throughout this pandemic. So we want to take a moment to do that. And Blake, do we have any questions?
Yes, we do. Just want to emphasize again, I did get someone asking for the handouts. I'm sorry if they're not working on there. That's why we did try to do both. But as always, we will send out an email with the presentation, the recording of the webinar, as well as the Q&A document. So just wanted to let everybody know that. Define no staffing shortages, and then the same person put just us or all facilities in area. So I don't know if those correlate or.
Okay, so I assumed when I read this the way it was written that they're talking about an individual facility level plan, and you can't have any staffing shortages. And that's long been a concern of mine because they don't ever define what a staffing shortage really is. And so I guess, you know, you would have to use your best judgment in terms of what your facility needs are, with the idea that a surveyor could be coming behind you to think about that. I'm always concerned about whenever they say, do you have adequate staffing? Some of the questions that you have to report on, do you have adequate staffing? I think that that's a bomb waiting to happen. So I think you need to be thoughtful about that, but there is no good answer.
Okay. Does the risk of COVID and its potential harm to other residents result in those with dementia not being able to decline testing? In other words, do residents lose their rights to refuse because of the potential harm to those around them?
I think that that's an important question and one that has been discussed at length in the state, with the state, and they have not come to an answer about that. The public health staff pretty much are for mandatory testing of everybody. However, the governor and the state have not made that decision to do that. So I do believe that there are issues around that, and I think that's one of the reasons why CMS wants to make sure that everybody has a plan to identify what to do if that happens. I keep expecting that they're going to make it mandatory, but they have not yet. So you need to have a plan for that. I do think that there's some risk, and right now the public health section and the other Medicaid and Department of Health and Services people are kind of duking it out. They keep, or some of them are referring to resident rights all the time.
Okay. I keep hearing about alternatives to the deep nasal testing. Are facilities here in Michigan using saliva test or oral swab test? I know that other states have been using these alternatives.
The CDC has, I think about maybe 3 weeks ago, removed its preference for the nasopharyngeal test, which we know is extremely uncomfortable. So technically those other test types are allowed. However, when we talk to the department and in the testing work group, they pretty much said that everyone is using the nasal pharyngeal test yet in Michigan. I don't know that there's any requirements about that. I think you could probably, if you don't want to, you want to try another, you could talk to the local health department about that. They are the coordinating people in your community.
Okay. Just an FYI, we were on track to test staff this week, but test kits arrived with no labels or forms or transport bags. We were told originally we would have to send tests to a commercial lab, but there seems to be confusion. The county health department is telling us to wait, although they have now received the forms. So far, it has been very disorganized, and they have very few answers to our questions, hoping this process smooths out soon.
So, first of all, I would ask, is this part of the statewide baseline testing plan, or is this testing on your own? And the second thing is that anyone on the call, we talk to the people in public health every weekday. So if you have a question with your issue with your local health department, please let me know who that health department is. Give us an email, and we will take that message straight to public health.
Okay. Let's see. Do we need to have a dedicated area within our assisted living for COVID-positive residents? All assisted living rooms are single studio apartment type rooms, so the resident can be fully isolated in their room. We would not want to transfer a positive assisted living resident to our SNF at this point because our SNF does not have any positives. The SNF does have a designated area for COVID if we need it, but we would not transfer in a positive unless we already had a positive in the SNF.
I think that's a hard question. I'm not sure that there's a clear answer. I know that I don't believe there's any guidance, although, again, I'm going to go through all the CDC guidance for cohorting. And unfortunately, you know, in any guidance, there's not an answer for every scenario. I think that you'd have to weigh, I would be concerned if you had COVID positive patients in single apartments that kind of were throughout your facility. So if you had a single apartment and you thought that you could isolate that person, but you'd really have to look at whether or not you had the ability to don and doff PPE in a safe area. You'd have to look at how people coming in and out of that room would be going through other common areas. So I would be a little concerned about that. And if indeed you have a dedicated unit in your SNF that is really isolated in an appropriate way, it does feel to me like that would be a better place. But again, there is no 100% clear guidance about that. And I think that you would have to look at your facility and your risk and make that decision on your own. And if you want to talk to me about that more, I can follow up after the Q&A.
Okay. We have to notify employees of positive residents within 12 hours, but do we have to notify employees of other employees who are positive? Can you clarify this, please?
I would have to look at the exact wording of that, but I would believe that you do.
Okay.
I will go back and look, but I think that you do.
All right. For IL, is there anything prohibiting residents to gather in small groups of 10 or less? We understand no restaurants, salons, no visitors, or gyms.
I believe that at this point, one of the latter executive orders do allow groups I believe that would apply to IL of 10 or less, but you have to maintain social distancing, and I think perhaps masks, I think, are in order too. You still have to have universal source control.
Okay. Where are we with having non-essential workers continuing to work from home where possible? When should those restrictions end?
I think that there are different criteria for opening different kinds of non-essential services. A lot of it could be based on your individual needs in your facility or business service. I think I would have to look at what they're doing, how they're doing it, etc. But some are opening. and I'd have to go through that EO and look at the last EO in the last, I think, 24, 48 hours has a very, very detailed description of the different kinds of businesses that we would have considered non-essential earlier and how they're reopening and what some of the requirements are. And the CDC also has requirements for non-healthcare facilities to open as well.
Okay. It looks like that was the last question. So with that, I believe that we will be concluding today's COVID webinar. We would like to thank our members. I believe we got up to around the mid-60s for participants today that took time out of their busy schedule to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. We do have another COVID Safe and Calm webinar, I should say, I believe coming up next Tuesday at 2 p.m. Eastern Standard Time. You will receive a reminder, I believe an hour before that. And then, Deanna, are we planning on having this COVID-19 webinar next Wednesday, or are we going to go Friday again, next Friday?
Yes, I'm glad you brought that up, Blake, because I want to remind everyone that starting June 1st, we will change our webinars to twice a week, Wednesday and Friday. There seems to be so much to discuss, and I want to make sure that everyone has time for questions. Next week, to my knowledge right now, the next webinar is Wednesday morning, barring any last-minute committees that may want us to talk to them. So the next webinar is Wednesday morning, and then we will follow up starting June 1st on Wednesdays and Fridays.
All right, thank you very much for that. Other than that, I think that will be everything. So I hope everyone has a great Memorial weekend. Hopefully you have that Monday off and have a great time. Everyone have a great day. Thank you.